I'm Matt Geiger. In this video, I'm going to give an overview of the healthcare provider system with a focus on how it impacts and interacts with U.S. healthcare policy. So in 2018, we spent $3.6 trillion on healthcare, or about 18% of U.S. GDP. Of that amount, 33% went to hospitals and 20% went to physician and clinical services. And those are the two slices that I'm going to cover. So a little over half of our total healthcare spending, starting off with the hospitals. For reporting purposes, community hospitals are usually split into three different buckets: nonprofits, for-profits, and government-owned. Nonprofits make up the bulk of all the hospitals, roughly 60%. And being a nonprofit hospital is a tax status. That means that the hospital has to provide a benefit to their community, and that can take a number of different forms. Charity healthcare, a portion of unreimbursed healthcare on plans like Medicare and Medicaid, health professional education, research, or just cash that's used for the betterment of the community. As a part of the nonprofit designation, the hospital is exempt from all taxes, so no property taxes, sales taxes, or state and federal income taxes. Also, they can receive tax-free donations, and they can benefit from financing with tax-exempt bonds. Nonprofits make up the bulk of both the largest hospitals and the most profitable hospitals too. They make up 8 out of 10 of the largest hospital systems and 7 out of the 10 most profitable hospitals. The most profitable ones are usually bigger hospitals in urban areas that don't do a whole lot of research. But on the other hand, nonprofit hospitals also make up the vast majority of rural hospitals, which are totally different from the big, rich hospitals near cities I just mentioned. About a third of all hospitals are rural, and of those, the vast majority are nonprofits, and also those are critical access hospitals, meaning that they're the only hospital within 35 miles. That designation gets them more money from Medicare. In general, though, rural hospitals are not very profitable and have struggled to stay open over the last few years. A lot of these hospitals are vital to their area, and closures devastate the health of the local communities. For-profit hospitals make up about 20% of hospitals. Like any other business, individual hospitals may or may not help their community, but their goal is to make money for their owners. On that list I showed you earlier of the largest hospital systems, the remaining two that weren't nonprofits were both for-profit and are both publicly traded companies. HCA Healthcare is number 65 on the Fortune 500 list, and Tenet Healthcare is number 174. The vast majority of for-profit hospitals are in urban areas, which makes sense because, as we just mentioned, rural hospitals have been struggling just to stay open. So not only are rural hospitals bad investments for these companies, but they need the nonprofit tax breaks just to survive. Government-owned hospitals make up the last 20% of hospitals that we haven't already talked about. These are operated by either state or local government, sometimes in conjunction with a public university. They're disproportionately located in rural areas, and they serve low-income communities often, meaning that they also tend to have the highest number of Medicaid patients, highest number of uninsured patients, and have the lowest profit margins among all hospitals. What's interesting here isn't necessarily the differences between these three types of hospital ownership, it's more what they have in common. Research shows no difference in pricing between nonprofit and for-profit hospitals. They both tend to use their profits to buy other hospitals and doctor businesses called practices to create large networks, and nonprofits and for-profits behave similarly once they get that negotiating power. That raises the question of how nonprofits deliver their community benefit, and that's actually one area of criticism of nonprofit hospitals. When a hospital is nonprofit, the local community loses out on a huge amount of taxes, so you'd expect the hospital to deliver community benefit exceeding the tax breaks that they're getting. But studies usually show that communities would get more value if they just collected the taxes. So despite the common hospital breakout of nonprofit versus for-profit versus government-owned, the key difference really seems to be the urban-rural divide among hospitals. Rural hospitals financially struggle, but their existence is key to their community's health. Urban hospitals have plenty of insured patients, so tend to behave just like any business, whether for-profit or nonprofit, making calculated decisions to just continue to grow. So now that we have a good foundation, let's get into how these hospitals make their money and where their incentives are. A massive oversimplification is just that hospitals negotiate rates with insurance companies for procedures, supplies, lab, everything, and then those agreements dictate what the hospital's paid. But there's lots of nuance to how this comes about, and that process starts with the hospital charge master. That's the book that says what the hospital charges on everything from a surgery to an aspirin. On the charge master, hospitals can charge whatever they want. Sometimes they base prices on what competitors are charging, or they increase a set percent every year automatically, and the hospital has an incentive to set charge master prices as high as possible for a couple reasons. First, insurance companies negotiating the rates want to tout to their customers that they got them the largest discount off hospital prices. So the more hospitals charge, the more insurance companies can discount during negotiations. As long as patients are insured, they pay, or the insurance company pays, that lower negotiated price anyways. So it's kind of like a win-win for the insurance company and the hospital. But for people who are uninsured, they pay that full inflated chargemaster price. But there's another bad incentive for inflating chargemaster prices too. Remember that most hospitals are nonprofits and they need to show community benefit. Well, a major way hospitals do that is by showing uncompensated healthcare costs, essentially free healthcare based off the chargemaster price. The higher that they make that chargemaster, the higher the hospital can show as community benefit when the uninsured person can't pay. So the hospitals have a couple key incentives here. The first is what we just talked about, to raise chargemaster prices to give insurance companies larger discounts and to increase their community benefit. There's an offsetting incentive controlling prices. Hospitals don't want to just write off all uninsured people as community benefit. The hospitals expect some percentage of them to actually pay, but the net impact of this is what anybody who's been to the hospital has seen: very high chargemaster pricing. But there's a second, much bigger incentive here. Most of the hospital's patients are insured, so hospitals need market power to negotiate higher rates with those big insurance companies. One way hospitals have done this is by buying up other hospitals, forming local or regional monopolies. Health insurance companies have a very weak incentive to negotiate down prices because their profit is based on a markup of healthcare costs. The net result is that insurance companies agree to much higher prices from hospitals with local monopolies. Insurance companies do have more negotiating power with smaller hospitals, though, or those in markets with multiple hospitals that are serving the same general area. Research has shown big disparities in pricing between hospitals with local monopolies and those in markets with multiple hospitals. Knowing this, hospitals have consolidated over the past few years, driving up prices. So everything I just talked about is how private insurance works, but Medicare and Medicaid are different. Medicare is the insurance program for people over 65 years old. Studies show that Medicare pays hospitals roughly half of what private insurance pays. There's no negotiation between hospitals and the government. Medicare just says what it's going to pay based on a formula that CMS, that's Centers for Medicare and Medicaid Services, calculates. So for hospitals, what they do is they assign a diagnosis-related group, or DRG, to each patient that's treated in the hospital based on the patient's diagnosis, severity, and the length of the stay. A formula then determines each DRG weight based on the relative cost of treating that diagnosis. That DRG weight is then multiplied by a hospital-specific payment rate that CMS comes up with to account for local differences in wages, rent, things like that. And then also there are adjustments for teaching hospitals, hospitals that treat a higher proportion of low-income people, and rural hospitals. Remember, we talked about critical access hospitals earlier. They are the ones that benefit from the higher Medicare reimbursement through this base rate. Hospitals are also penalized if they have higher levels of readmissions or hospital-acquired conditions. Pay for performance has also gotten a lot of attention over the last couple decades as a potential solution to either improve health outcomes or control rising healthcare costs, or both. These are pricing systems where you pay based on health outcomes or patient satisfaction surveys. I briefly mentioned one way this has been implemented by Medicare. Hospitals get lower payments if they have high readmission rates or high rates of hospital-acquired infections. Lots of private health insurers have started modeling their payment methods with pay-for-performance metrics too over the last few years. Studies haven't shown any improvement for these sorts of policies on either health outcomes or cost savings, so I'm not going to spend a whole lot of time on the specifics of how these programs work though. Physicians are the second largest piece of the healthcare spend pie, about 20%. About half of all doctors are general practitioners in the US, the other half are specialists. Specialists make significantly more than general practitioners, explained by the fact that they need more years of training, which varies depending on the specialty. After 4 years of medical school, residencies range anywhere from 3 years for general practitioners to 7 years for the longer specialties like neurosurgery. The US has a history of doctors in independent or small group practice, but since roughly the late 80s, this has been slowly changing. Just a few years ago, the percentage of doctors employed surpassed the percent of doctors who owned their own practice for the first time. That's not to say that all doctors are employees of hospitals now, though. There's still a wide variety of doctor practice ownership. Doctors still directly own over 40% of practices, while a third of all doctors work for or are owned by hospitals. There's still a wide range in the size of physician practices too, with a majority of practices still being made up of 10 or fewer doctors. But the large practices are skewed toward more hospital ownership. The nature of the industry has been slowly shifting over time towards employment in larger groups for the last couple decades, and there are a couple trends that are really driving that. To get reimbursed by insurance, doctors need to submit a form to the insurance company. That's called billing. Complexity of insurance billing and the fact that doctors just want to practice medicine without dealing with that whole business side is pushing young people towards employment. Also, women make up a larger proportion of young doctors, and they're opting for the flexibility of employment over ownership. But the other driver is that hospitals are acquiring practices, and practices are merging with one another to form larger practices. To a small extent, this is so they can gain more market power in dealing with insurance companies, like with hospitals, but since there's so many small practices, it just doesn't work the same. It's near impossible to get the same scale or corner a local market the way that hospitals can. So the primary reason for practice consolidation is that hospitals want to acquire physician practices and use them to make money for everything else in their system. Medicare pays more for the same outpatient practice if it's done in a hospital versus a doctor's office. So studies have shown the hospital flips more procedures to their hospitals rather than do them in the doctor's office. Doctors only refer patients to specialists who work for the hospital. Doctors direct patients to get lab done by the hospital, often at significantly higher prices. And with the consolidation incentives and the natural aging of physicians who own smaller practice, I would expect the trend of larger and larger practices and hospital ownership to continue at a moderate, steady pace for a long time. We already talked about how hospitals get paid, and doctors are the same with some key differences. Just like hospitals, the largest payer is private insurance. Remember, hospitals have significant leverage to negotiate reimbursement rates with private insurance. Most practices don't, though, because of the size and the number of practices. Practices can choose not to accept insurance from an insurance company that reimburses at a lower rate, but then the practice is giving up most patients who have that type of insurance. Medicare reimbursement for doctors is similar to hospital reimbursement too. Medicare reimburses physicians on average at about 70% the rate of private insurance. The CMS, Centers for Medicare and Medicaid Services, sets fees for over 7,000 different services. For hospitals, this was based on the cost of treating each diagnosis, but for doctors, the rates are set a little bit different. They set it for each service or procedure based on physician work. That's time, technical skill, mental judgment, things like that. Also, practice expenses like equipment and employees, and malpractice insurance. These three factors are used to determine what they call an RVU, or relative value unit. Basically, that puts all services on an apples-to-apple basis for payments similar to what DRGs did with hospitals. That's then adjusted for different practice costs in different parts of the country, right? Same as hospitals I just talked about. And there are also a few other adjustments, like an increase for underserved areas and decreases if you don't use electronic health records. Each of those calculated units is worth a certain dollar amount that's set by Congress, which determines what Medicare pays the doctor. So overall, a very similar process to hospitals, but the way RVUs are set is a lot different than the mathematical formula that automatically sets DRGs for hospital reimbursement. CMS has historically relied on a committee of the AMA, American Medical Association, to come up with the data underlying the RVUs. The CMS takes about 80% of the AMA recommendations on average, so this AMA committee is very influential in the process. Committee recommendations have historically favored specialties. Of 31 committee seats, specialty societies get 21, while primary care gets only 4. The primary care seats also rotate every couple years, while specialty seats are permanent, so primary care groups aren't as effective at navigating the committee politics. Also, each physician society surveys its members to determine time and complexity of different procedures. Since everybody has a financial incentive to overstate these, specialty reimbursement doesn't come down, even if a new technology makes a procedure significantly easier to perform. This ends up hurting primary care disproportionately, which is centered around person-to-person evaluation work that can't be improved by technology as easily. So overall, what we see from physician incentives is that there's a strong incentive for physician practices to consolidate and join hospitals. New doctors have a strong incentive to go into specialties because of those outsized reimbursement rates, and they have an incentive to join larger practices and hospitals. Hospitals can negotiate higher reimbursement, make more money off of all the inefficiencies among different parts of the healthcare market, and they can comply with expensive requirements like sophisticated billing team and electronic health records. What I really take away from all this is the disparity between the simplistic story politicians tell, blaming insurance companies for higher prices, versus the reality that higher prices are caused by a complex web of bad incentives. Studies have shown that hospitals are all rational, profit-maximizing actors, even ironically the nonprofit hospitals. Hospitals have significant negotiating power because they've taken calculated steps to get to that point, while insurers have almost no incentive to hold that spending in check. It's easier for the politicians to side with the massive healthcare lobbies, as opposed to confronting a nuanced situation the public may not fully understand. But we're all very literally paying the price for that. Thanks for watching. Hey, if you found this video interesting or useful, please give it a thumbs up, put a comment below, and subscribe to my channel to get any updates on new videos. If you didn't like it, you should probably go ahead and put a comment below too to let everybody know. Either way, thanks for watching.